Thank you, Amanda. I've been an AME member for 45 years, and I am extremely grateful for the rapid action and support of WHO, IFMBE, CED, and everyone else in providing free access to so many standards and convening committees to come up with new guidance and guidelines for ventilators, disinfection, and other practices. It's very important, and we appreciate your being here and the leadership AME is showing in this pandemic. I'm pleased to introduce our next speaker, Dr. Furman, who is representing ECRI, and let me make the same thanks to ECRI for its incredible contributions to free webinars, free materials, reports, inspection, cleaning, and other products for our community, both to WHO and to IFMBE CED. I, just for disclosure, was a vice president at ECRI from 1975 to 1990, and really have a great respect and regard for the work that you and the team are doing during this pandemic. Dr. Furman, please fill us in from a physician's perspective, what is happening and what you're doing.
Thanks, Elliot. Thank you. Hello, everyone. As Elliot stated, I'm Andy Furman, Executive Director, Clinical Excellence at ECRI, an independent nonprofit trusted authority on medical treatments and products. We are driven to advance effective evidence-based healthcare globally. I was asked to provide a clinician's perspective on decontamination and disinfection during COVID-19. Much of this perspective revolves around PPE. And so I wanted to spend a few moments on some important context for clinical engineers and administrative leaders alike to help engage clinicians. And as you see here on the slide, of being safe and feeling safe. There's emphasis and distinction for a reason. I and others will and have spoken about making evidence-based decisions, but please also take the time to understand some contextual elements that affect clinicians. Many, including myself, were accustomed to having supply chain assurance. If all a clinician has ever experienced in a working environment where supplies were a given, where they could simply know a patient is here for a complaint of respiratory symptoms, even possible tuberculosis exposure, let's say. Now, having all of the supplies needed when entering a room to dispose of upon exiting the room becomes the norm. This is where clinicians in the world as a whole can learn from each other and be less wasteful. However, it starts with taking the time to listen to and understand the clinical staff and what they regard as feeling safe. This might require some extra time to reconcile when the feeling of safety is actually contrary to evidence of being safe. Add to that, prior to COVID, infection risks were low and disease processes mostly clear. I remember in medical school when I learned about infectious diseases, and before that, I had never really even considered exposure risk. My anxiety was heightened as I learned, and ultimately overcame as knowledge about specific diseases was better understood. That anxiety returned, as an emergency medicine resident with minimal procedural experience, sharp objects, blood exposures, and as mentioned before, HIV. Again, the knowledge base increased and anxiety lessened. Now with COVID, we have this complete unknown. No textbook to read and no mentor to call on to alleviate fears. Fortunately, organizations like the World Health Organization and ECRI are providing insights to help change that. And it's not completely new. There's much already known about viral pneumonias, the success of disinfection and decontamination of coronaviruses, proper PPE. I know I can trust organizations like specialty medical societies, national health protection agencies, and the World Health Organization to deliver me what they know. And I want to also be able to trust hospital leaders to interpret and deliver information to me. But, and this is a big important but, guidance must be clear and concise. Please don't send me as a physician a 15, 50, 100 plus page policy to read. What actually makes sense for my workflow? I'd love a link to a more detailed information to learn more, but give me the simplified and clear process which I can follow to treat my patient today. Now, being safe involves evidence analysis, and chasing the latest trends can be a very costly mistake. Many might say, though, more advanced technology must be better, right? Ubiquitously installing UV systems and copper surfaces, treat everything with vaporized hydrogen peroxide. No, this again is where the world can learn together, and ECRI is spending much of its time reviewing technologies on the basis of their evidence versus a manufacturer's claim is critical. UV can be a great supplement to a disinfection program, but does every facility need to go and purchase UV units for SARS-CoV-2? No, they do not. Preface this with that the last thing I want to suggest is that innovation should be stifled, slowed, stopped in any way, but more just to take a step back and understand what is known about the foundational evidence. Next slide, please. So let's transition a bit to how we manage and recover together with some cleaning and disinfection specifics. So what do we know? Much is expected of frontline clinicians. 35% of facilities reported to ECRI that nurses are performing terminal cleaning. If nurses are needed to clean and disinfect, please train them in a structured way based on policies and guidelines, many found via World Health and ECRI resources. Extended use and reuse of PPE works. Evidence supports prioritizing extended use. That's where a clinician wears the same respirator over the course of a period of time, moving from COVID patient to COVID patient, for instance, over reuse or repurposing of a respirator, because respirators may readily spread infection by touch with donning and doffing, clinician self-contamination, if you will. That being said, reuse does extend the supply, and many methods have been evaluated. Decontaminating respirators by steam, vaporized hydrogen peroxide, or ultraviolet germicidal radiation may be safe and effective in some settings. Each method needs to be tested on each respirator model because model materials vary. ECRI urges caution and careful consideration of all available options to identify the decontamination process that best meets a facility's operative needs and budget. Now, vaporized hydrogen peroxide has looked the most promising and recently has gotten much of the press, but it is not without safety risks. Hydrogen peroxide degradation releases pure oxygen, which is a fire and explosion hazard. Vaporized hydrogen peroxide can cause lung and airway irritation at concentrations as low as 75 parts per million and serious injury at higher concentrations. Thus, accidental worker exposure is a significant risk. And consider this, greater than 20% of respirators become unusable without decontamination cycles of any kind. So just because mechanical wear and tear after donning and doffing. Here's my industrial grade respirator, that I use while installing fiberglass insulation in my home. I reused it over and over through the course of ECRI's lab webcast series, leading to both straps breaking and a softening of the material that, although more comfortable, really makes me question the effectiveness. Spraying people with disinfectants does not work. It's not recommended under any circumstances, quote unquote, as per World Health Organization guidelines. World Health and US Centers for Disease Control report that SARS-CoV-2 virus is primarily transmitted between people. So spraying the outside of a healthcare worker will not effectively stop transmission the next time they cough or speak for an extended period of time. Now, what do we need to know more about? Where and when can necessary supplies be obtained? ECRI continues to monitor this and will be hosting upcoming webcasts with supply chain leaders. How will quality of supplies be assured? There are many new PPE suppliers on the market. Preliminary ECRI lab analysis reveals broad discrepancies in quality, even from the same manufacturer and within the same batch of masks. A clinician can't be worried whether or not they're one of the lucky ones who gets one that works. What is the best use of limited resources? This is where all stakeholders need to come together to be innovative. The evidence can help inform. We know temperature screening is an ineffective way to control spread. So perhaps best not to invest in advanced technology to take temperatures. We do know that telehealth programs conserve PPE. So do invest in telehealth to reach patient populations otherwise unreachable, or check in on patients who are COVID positive and there is worry about decompensation. Share what you learn. Use forums such as this one, journal submissions, and general word of mouth locally and regionally. When a patient does have to seek care at a facility, what is the best way to keep them and clinicians safe? And don't forget the part about the feeling safe. So please share evidence and data with clinicians to differentiate a technology or process that works from one that does not. Together, patients can then optimally be and feel safe as well. Next slide, please. Here are some resources available to you. The COVID-19 Resource Center is a publicly available site filled with a variety of ECRI content, including supply chain information, clinical evidence assessments, where our team of doctoral level research analysts deliver comprehensive and reliable evidence for balancing outcomes, quality, and costs, lab webcasts, including more in-depth information from ECRI engineers and industry experts about topics I discussed today, and ECRI position statements, where evidence is either lacking but logical conclusions can be made, or evidence is clear and needs further point of emphasis. Take a look when you have a moment, reach out to ECRI. Perhaps we can help solve a problem with you. With that, back to you, Elliot and Kathy.
Andy, thank you so much. We greatly appreciate ECRI's trustworthy and unbiased feedback and assessments. It's very, very important for this COVID-19. When we come back to the discussions, I want to bring up the issue of counterfeit PPE that's flooding the market from many sectors.